Hello everyone. This presentation is aimed at studying the basic evaluation of a child who is presented to us with developmental delay. Now, if we go through this presentation in as much attention as this attentive meerkat, we are likely to blossom our knowledge like this beautiful orchid. And in this, we would endeavor to first identify what would be the possible pattern of delay in a child who is presented with the delay in one of the concerned area. So either predominantly we could be handling a case of global developmental delay or predominant motor delay or predominant language delay. So based on the pattern of delay, how do we approach the child with tentative etiology in the back of our mind and taking a comprehensive history examination and a series of investigation to come to the possible diagnosis, and also we should make an attempt to identify the red flag signs. So first is the very pertinent global developmental delay. What do we understand by this terminology, global developmental delay? So actually it is a subset of developmental disabilities defined as significant delay in two or more of the following developmental domains, either gross or fine motor, speech and language, cognition, social personal, and activities of daily living. Significant delay is defined as performance which is less than 2 times the standard deviation. Significant delay is defined as performance of less than equal to 2 standard deviations below the mean on age appropriate standardized norm reference testing. That means if we perform the DQ assessment less than 5 years of age or IQ assessment more than 5 years of age, a cutoff value somewhere around 70 will be indicating a significant delay. Global developmental delay is the terminology that we use below 5 years, and above the 5 years of age it is replaced by the terminology of intellectual disability that was previously known as mental retardation. Now very importantly, there are few terminologies like dissociation, developmental regression and deviance. So what is the difference between all these? Deviance is that in the sequential milestones development, if there is a milestone which is out of place, that is deviance. To make it more clear, for example, we know that the developmental progression in the gross motor domain is cephalocaudal. That is, first the child learns to hold head, then sit, then stand, and then walk. Between sitting and standing, there is an intermediate stage of creeping and crawling. But some children, instead of crawling directly from sitting position, go on to stand or walk. Now this is a deviation from the usual sequential milestones. This may be normal, but sometimes this may actually be an indicator of some underlying neurological deficit. Another example is hand preference. Now hand preference usually comes around or after 2 years of age. An early hand preference less than 2 years of age again is something which is deviation from the normal, and it may indicate the presence of congenital hemiplegia. Other than that, there are two more terminologies, dissociation and developmental regression. Dissociation is that there is a discrepancy between the different domains. That means there may be a child who has motor delay, but his cognitive and social domains may be absolutely okay, like a child with cerebral palsy without associated intellectual disability, or a child with autism who has more of social and language delays, and his motor performance may be in fact faster than the peers. So dissociation is never normal. Deviance may or may not be normal. Another terminology is developmental regression. If we have loss of milestones that persist for more than 3 months, that is known as developmental regression, and loss of milestones at any age is a very important red flag sign that should alert the clinicians. So this is a trajectory, and you know that the development proceeds like this. It may plateau, it may regress, there may be a waxing waning course, or there may be a delay which is in all domains parallel to or coming at a distance from the usual trajectory. So it is not uncommon to have children with global developmental delay. The estimated prevalence is 1 to 3% of children less than 5 years, which increases to 5% by 14 years according to WHO estimates, and few studies even take it to up to 10%. Indian studies have reported a prevalence of 1.5 to 9.5%, and it has found to be around 7% in the urban children. Undernutrition and prematurity were found to be the most prevalent etiological diagnosis in one of the studies, and less than 2 years the Indian studies have found a prevalence of around 1.5 to 2.5%. Now, whether there should be an attempt to find the cause in a case of developmental delay, what are the implications? See, if we go to the entire diagnostic algorithm from history, examination to ancillary investigations, we will be able to find out the diagnosis, the causative diagnosis, ranging from 10 to 81%, depending on what is the underlying etiology, how common it is, and how much is the depth of the investigative evaluation. So, see, the importance of determination of causality is that it provides a closure to parents. It tells them that this is the possible cause and what therapeutic measures they can undertake. So, it has implication regarding treatment, prognosis, finding out what are the associated comorbidities, and if it is a heritable disorder, what is the recurrence risk, and accordingly counseling of the families. Then there may be some disorders which may be preventable. So how do we implement a prevention program if we do not know the cause? And this empowers the affected family in planning for their child. In fact, some of the parents would go in for chorionic villus sampling to undertake an antenatal genetic confirmation of the diagnosis. And very importantly, once it provides the closure to the parents, it limits further unnecessary testing, further hopping or window shopping or doctor shopping, because some of the disorders may not have specific therapeutic interventions. So we know that the etiology is actually heterogeneous. The major etiological categories include intrapartum asphyxia, still in most of the developing countries. It is the commonest reason in as high as 22% of the patients. And then cerebral dysgenesis or malformations in 16%, chromosomal abnormalities in 13%, genetic syndromes in 10%, and psychosocial deprivation in another 10%. These top 5 categories account for 80% of the etiological diagnosis. Other reasons could be term periventricular leukomalacia, toxins, metabolic, and infectious. There was one study done from the UK, which is known as the Progressive Intellectual and Neurological Deterioration Study, and it found that for the progressive causes, the most common 10 causes included NCL, MPS, Rett syndrome, MLD, ALD, GM2 gangliosidosis, Niemann-Pick type C, and GM2 gangliosidosis type 2. So once we know that we have to come to a etiological diagnosis, what should be our approach? We should take a history. In history, we know that we have to begin right from antenatal period, go on to perinatal and the postnatal period. What should be the components? In the antenatal history, we need to know what was the age of the mother at conception, and some of the disorders like particularly the Down syndrome can have. So what should be asked in history? As we know that the history begins right from the time of antenatal period in the developmental history. So we should ask about the age at conception. Many of the developmental disorders like Down syndrome and associated global developmental delay may be dependent on advanced maternal age, and things like Fragile X syndrome may be associated with advanced paternal age. Then multiple gestation, as second twin or the consequent number of the twin may be more prone to have birth asphyxia. Then history of infertility, recurrent fetal wastage, as that may indicate an underlying chromosomal abnormality. RH incompatibility, as it may lead on to neonatal hyperpill and later on bind sequelae, and choriothetoid kind of cerebral palsy. Any underlying medical conditions like severe anemia, pregnancy-induced hypertension in the mother, then teratogen exposure, and any time if abnormal ultrasound has been documented, which may pick up some gross congenital malformations, especially the level 2 ultrasound. In the perinatal period, what we should focus on is the presentation. Any presentation other than the normal vertex presentation like breech or shoulder may be associated with obstructed labor or prolonged labor. Then type of the delivery, whether it was normal or it required some kind of aid like forceps or Ventoux, which could have indicated some birth injuries. Then what was the duration of labor? Anything more than 24 hours in a primary gravida is prolonged labor. What was the place of delivery, whether it was institutional or conducted at home, who conducted the delivery, whether the child required active resuscitation at birth, whether there was prematurity associated or there was actually a difficult delivery, and if there was sepsis setting. Then what was the condition of baby at birth? So in that we need to know about the Apgar score, if there was any cyanosis, jaundice, if the child faced any hypothermia or hyperthermia, or if there were obvious congenital deformities, and what was the weight at the birth. In the neonatal period, we need to find out if the child had neonatal encephalopathy that could manifest in the form of seizures like twitching or convulsions, or even excessive irritability and excessive crying, inconsolable child, or in the HI3 the child could be listless, lethargic, could be having persistent vomitings, and if there's jaundice we look in for RH or ABO incompatibility as well, and we ask for any sucking difficulties. In the developmental history, we actually have to ask about the acquisition of developmental milestones in all domains. Even if the presenting complaint may be limited to one domain, that means maybe the parents may be saying that the child does not walk yet for maybe a 2-year-old child, but we do not stop at the gross motor domain in this particular child. We take the history for all the domains. We ask about the age of initial concern, what was the progression, what was the current capability, and thus we ask for each of the domains. Then we also ask what are the activities of daily living like, how are the play skills, and very importantly we ask about any loss or regression of skills. Then we always take the history of risk factors. Protective social factors are equally important. The protective social factors include the psychosocial factors. If the mother is educated, there is a good family income, and there is a good family support, there is opportunity to interact with other children in a safe environment, and there are consistent expectations with age appropriate limitations. These become important protective social factors which may give a very nurturing environment to the child. In the family history, we need to not only know the status of siblings, but we also need to know about 3-generation pedigree, the parents and other relatives, regarding if they had developmental delay, what was their health like, what was their school attainment or school performance, any learning disability anybody faced, any behavioral or psychiatric problems, any significant neurological impairments like cerebral palsy, global developmental delay, autism, or intellectual disability, or developmental language impairment, epilepsy, neuromuscular disorders, parental consanguinity, and ethnicity. Coming to the physical examination. So a comprehensive physical examination would include a general physical examination as well as the neurological examination. In the general physical examination, we need to know the growth parameters, especially the head circumference for micro as well as macrocephaly, growth velocity. We have to look for dysmorphology, minor as well as major anomalies, and we have to look at the parents, because the features that we might be interpreting as dysmorphic may actually be ethnic in origin. Then cutaneous markers of achomatosis like ash leaf macules, cafe au lait spots, shagreen patches. Then hair for any hyperpigmentation or any kinkiness. Then eyes for cataract, fundus examination for cherry red spots, retinitis pigmentosa. We look at the teeth for hypodontia, gums for any blue line, nails, which could be indicating the markers for even severe anemia. Then we look for joint laxity, elasticity for any possible underlying connective tissue disorder. We look at the spine. We palpate the abdomen for possible organomegaly, especially the hepatosplenomegaly that happens many a times with storage disorders. Few of the findings that we can see in general physical examination include the hair, whether they are hyperpigmented as in the case of hyperhomocystinemia, or they are woolly as in the case of neuroaxonal dystrophy, or they are kinky as in the case of Menkes kinky hair disease. In fact, if we take a sample of these kinky hair and observe microscopically, they appear to have distortion called as palai torti. Also, we can see some typical rashes like facial rash or perineal rash in the case of organic acidemias like propionic acidemia, and also similar rash is seen in the cases of biotinidase deficiency. So these are few of the pictures. So this is showing gum hypertrophy. This is showing gibbous, excessive Mongolian spots. These are snaps of a child with GM1 gangliosidosis. Then cherry red spot, which is in fact because of the deposition of the storage material in ganglion cell layer of the retina, the underlying macula shines through, and this looks like a cherry red spot in the retina. And these are bony specules seen in the case of a retinitis pigmentosa. So, the complete neurological examination should include the head circumference of the parents. Also, one needs to look at the visual and auditory apparatus integrity. If there is any drooling suggestive of bulbar palsy, and with that we'll substantiate with the jaw jerk and the gag reflex. In the motor, not only do we see the actual strength of different muscle groups at all muscle joints, we can get a fair idea of the proximal strength from the Goward sign and how the child goes up and down stairs. In the gait, how the child walks and runs, whether he's clumsy or he's well coordinated, how is his balance like, whether any abnormal movements, especially dyskinesias, are present, and how is the performance in the repetitive and successive task, give us a very vital clue about the neurological abilities of the child. And the status of primitive reflexes, whether they are still persistent and whether the protective reflexes have appeared or not as per the age, are very important part of the examination. The neurological examinations in a child with developmental delay is incomplete without developmental examination. So we will go in for developmental examination right after the complete neurological examination. In all of this, we look for asymmetry, abnormal. So for developmental examination, the most important thing that we need is appropriate equipment. We need to have a bag which contains lots of items that would include a red bangle which dangles with the help of a thread, visual patterns, a katori spoon, a car, a doll, a bell, a rattle, a foam board, scissors, 10 cubes which are 1 square inch in size, crayons, pencil, paper, and a bottle containing Cheerios. The prerequisites include that the child should be comfortable, he should be calm, he should neither be hungry nor sleepy. He should not have faced a serious illness and he should not actually be grossly unwell. It is unfair to examine a child when he is admitted for any acute illness. It should be done in a non-threatening, conducive environment, and one should, while doing the developmental examination, go from least to most intrusive parts. For example, once the child is in the mom's lap, we should first make just simple observation on the mother's lap itself and then examine on the table as we develop repo, and later on the child can be brought onto the floor to see for the gross motor capabilities. It is very important that vision and hearing must be examined during the developmental examination. So the developmental examination is a very important aspect of the examination. We have to assess in all domains, including the social, the language, the motor and the cognition. Amongst the motor, we need to do both the fine motor as well as the gross motor. The social sphere is best assessed during the free play of the child. So what we have to see is whether the baby is able to play peekaboo, whether he waves bye-bye, how he takes social cues from the mother. A child who is not very interactive with the mother also, it may be a red flag sign for the autism. Also, we need to see whether he has pretend play, he has interactive play, or he is more or less solitary preference. In the motor domain, if we look at the fine motor, so right from offering a red dangling ring less than 6 months of age to see how he whether he is reaching out for the objects, whether he overshoots it, then offering him cubes to see the nature of the grasp, unidextrous, bidextrous, transfer of the object, and then finally offering him Cheerios to see whether he has a mature or immature pincer grasp. Then later on, the blocks can also be used to check for the other manipulative skills, like whether he is able to copy or imitate the objects like a train, a gate, a bridge, stairs, which will be according to the age appropriateness. Also, whether he is able to assemble cubes in the form of tower. Also, the eating skills, they may either be taken as reported from the mother, or you can even offer a cup or a katori spoon and see how the child is eating, whether he's spilling from with the spoon or eating without spilling. The gross motor domain, less than 6 months of age, one does 180-degree flip maneuver, but more than that, the child as he goes about, either whether he can roll over, he can how he performs in the sitting posture, in the standing, walking, whether he cruises about furniture, whether he can go up and down stairs. We offer him a ball and see whether he is able to throw the ball or he is able to kick the ball. Also, whether he is able to climb up and down stairs, whether he is able to ride a tricycle or bicycle will also tell about his motor abilities. In the language domain, when we offer the picture book to the child, not only do we see his fine motor skill, how many pages he is turning, but also we can ask him either to identify the object, what is it, or name the object. Then this helps, these identification as well as naming both are attained at different timings. Also, we can ask him to identify colors, the shapes of the objects. We can either ask him to point at the body parts in the picture book itself or on himself or on a doll. Then while we are interacting with the child, we keep on jotting down how his language skills are, whether he is just producing cooing sounds or he is babbling in the form of monosyllables or bisyllables, or he is using words, how much is his vocabulary, whether he is able to join words to make phrases, sentences, whether he uses future tense, he uses plurals, he uses pronouns, and whether he is able to confabulate and tell a whole story. How many step command does he follow? 2-step, 3-step or 4-step command? Then for testing the cognitive domain, we offer him puzzles, usually in the form of simple form board, where he is asked to place or insert the geometric shape inside an appropriately cut out the shape. So first we offer the round shape and then the later other shapes like triangle, square and so on, and we see whether he is able to place or insert these shapes. Then also whether he has concept of numbers, whether he knows what exactly is 1. Then he can distinguish between big and small, on or under, analogies in the form of similarities and differences. So in the whole, this is a comprehensive overview of how do we go about with the developmental examination. Beyond that, in fact, the American Academy of Pediatrics and American Academy of Neurology says that when we have an unexplained, static, global developmental delay, we use a stepwise approach, and by the history and examination itself, we will have 17 to 34% yield of the causation. So in this history, we take all the history as we have discussed so far, including the newborn screening results and the family history, the physical, neurological and developmental examination. So these three parameters are going to tell us cause in 17 to 34%. Then we do directed investigations. If there are seizures or encephalopathy, we do electroencephalogram. If there is a suggestive history of exposure to maybe like enamel paints or batteries, then we get a blood lead done. If it was not covered in newborn screening, so all children should undergo thyroid profile. Then one should also know what is the status of the vision, hearing and psychological educational testing. And if the faces are syndromic, we need to take an expert opinion about it. After all this workup, perhaps we'll have some specific etiology which is suspected, or we may not be able to suspect any specific etiology. So if we are suspecting a specific etiology, then we go in for, depending upon the suspicion, we choose the test. If it is a genetic syndrome, which is a single gene, for example, X-linked intellectual disability, that we suspect if there are more than 2 male children in the family affected with intellectual disability. So we do the targeted testing for X-linked intellectual disability gene. But if we are suspecting a structural defect, like maybe a child with microcephaly who has a clinical phenotype of Miller-Dicker, we might go in for MRI brain. And if it is a metabolic suspicion, we do the metabolic workup. For example, he may be having abnormal urine odor, sweat odor or waxing waning course. Then we do a metabolic workup. Suppose we do not suspect a specific etiology even after the initial basic history examination, then in all severities and genders, the genetic testing gives us the maximum yield. So the preferable modality is microarray, array CGH. Otherwise, if it is not possible to do that, in at least a karyotype and a subtelomeric fish needs to be done. In females, if there is a moderate to severe delay with suggestive history of acquired microcephaly with motor stereotypies, persistent eye pointing, we do the evaluation for Rett syndrome using MECP2 gene testing. If it is a mild delay and for either gender, we need to look in for the fragile X syndrome using FMR1 testing. Suppose these come out to be normal, then we do neuroimaging using preferably the head MRI, and if we can get it done, we should consider the MRS as well. However, if it is abnormal, then we test parents and sibling also. That becomes the trio, the exome trio exome sequencing when we are doing testing the parents as well as the affected child, and we offer the genetic counseling. So in fact, the deciphering developmental delay study that found that using a combination of high resolution array comparative genomic hybridization testing, that is array CGH testing, as well as the trio exome sequencing, plausible genetic diagnosis was found in 40% of the children. So because this, in addition to the history and examination, we had an additional 10% diagnostic yield using only the genetic testing of microarray or targeted testing. But when we add a trio exome sequencing, 40% additional diagnosis could be made. So to summarize, genetic testing and MRI brain, if that is also non-diagnostic, then selected cases we do a metabolic testing based on the clinical judgment, and if that comes out to be abnormal, then we do the confirmation of the specific testing as indicated. To give an example, suppose we have neonatal onset seizures without any particular etiology, like there is no hypoglycemia, no hypocalcemia, the CSF is non-meningitic, and we do not have any structural problem, then we suspect that it could be glucose transporter defect, could be one of the possibility. So we do a specific metabolic testing, that is CSF is to serum glucose ratio. If that comes out to be less than 0.5, we go ahead with the genetic testing. So based on the specific metabolic testing, we may choose to confirm with a specific gene test. But suppose even after the metabolic testing we do not get any etiological answer, then we continue to have an ongoing follow-up and provide care to the patient, and we may consider referral to a medical geneticist. So how far and how deep the metabolic evaluation of a child with global developmental delay should go? So there was a systematic review in 2013 which identified 89 IEMs which were actually amenable to the causative agent or the cause underlying. So this is indicated if there are no newborn universal screening, or if the history or examination are suggestive of possible metabolic etiology. Some of the pointers being parental consanguinity, prior sibling loss, episodic decompensation, regression, dysmorphic features, or hepatosplenomegaly. So these IEMs included disorders of specific molecules like amino acids, cholesterol and bile acids, vitamins, cofactors, creatine, fatty aldehydes, purines and pyrimidines, metals, organic acids. Disorders that affect cellular organelles like lysosomal, mitochondrial or peroxisomal, or anomalies in glucose homeostasis and transport, urea cycle, neurotransmitter, and hyperhomocystinemia. So what it was suggested that since simple metabolic screens of blood like ammonia, lactate, serum homocysteine, plasma amino acids, acyl carnitine profile, copper ceruloplasmin, and urine testing for organic acids, purines and pyrimidines, creatine metabolites, glycosaminoglycans, and oligosaccharides give a yield in almost 60% of the cases. So it has to be done, should be done in all unexplained global developmental delay, where after the array CGH and after the MRI brain we do not have any particular cause. So we do the non-targeted this much testing. But if these are also not giving any answer, or if there are clinical pointers that the cause may be like pyridoxine dependent epilepsy, so we do a targeted testing individualized as per the case. So this becomes a second tier targeted testing, and this identifies 40% of the cases. So other tests would be like, if suppose we have underlying muscle weakness, we do a serum creatine kinase, and we do some radiological tests like bone age if macrosomia is there, skeletal survey if dysmorphism is there and we are suspecting a storage disorder, and we do electrophysiological tests like EMG and NCS if peripheral nerve involvement is there, and evoke potentials if we suspect that there are associated vision and hearing problems. The NHS UK also gives a similar evaluation strategy for global delay. It says that in initial assessment, you do all this workup, you do the history, comprehensive examination, and in this, it also asks that one should specifically look for episodes of hypoglycemia as well, and we do the Woods lamp examination. Then it says that the guidelines can be given for sequential investigations in the context of an individual's history and examination, and if if the opportunity is there, sometimes we may even need to do non-sequential investigation. So what does that mean? That the first line tests are the genetic blood tests like array CGH, microarray, and karyotype, and the standard blood test includes the thyroid, the creatine kinase, the urate, and all these. So it says that you do these tests, the starred one like biotinidase, lead levels, acyl carnitine profile, or TORCH screen if they are indicated by history examination, and you do a urinary glycosaminoglycan for MPS screen if guided by the history examination. And it says that you do the metabolic profile as a second line if there are pointers for the metabolic disorders. So that would include investigating for urea cycle disorders, small molecule disorders, very long chain fatty acids, and directed ones, opportunistic one, like if you are suspecting that this is a case of metachromatic leukodystrophy, you go ahead with the white cell enzyme aryl sulfatase to confirm it, and accordingly you do. It says you do MRI if there is abnormal neurology or abnormal head size, seizures, and vision problems. Similarly, there are specific indications for doing EEG or genetic testing. So this was about the global developmental delay. Now we will shortly and crisply look at predominant motor delay as well as predominant language delay. So if we have a child who has predominant motor delay, now at the very outset we would like to identify whether it is because of central cause or a peripheral cause. In the central cause, the lesion could be because of the malformation in the brain or HIE or IEM. In the peripheral lower motor neuron, that means in the motor unit, it could be at the level of anterior horn cell, nerve, neuromuscular junction, or muscle. In anterior horn cell, we consider things like SMA, ischemic myelopathy, or spinal dystrophism, or peripheral neuropathies, or myasthenic syndromes, or congenital myopathies, depending on the level of the lesion. So how do we get the clues? What is indicating what? So in this, if suppose if we have an abnormal head size or shape or dysmorphism, the possibility is that it is the brain which is involved. If there are fasciculation or asymmetry, it could be anterior horn cell involvement. If there are stalk-like legs, distal weakness, areflexia, pes cavus or palpable nerves, we think of motor nerve involvement. If it is a neuromuscular junction issue, that will have manifestations like ocular involvement, bulbar involvement, and fatigability. And in the muscle involvement, we may have pointers like selective atrophy, selective hypertrophy. We may have the presence of proximal more than distal weakness, and we may have some amount of preserved reflexes. So red flags, fasciculation, think SMA. They may deteriorate rapidly in acute illness. Facial dysmorphism, organomegaly, signs of heart failure and early joint contractures, think glycogen storage, MPS, Pompey's, and in this early enzyme therapy may be helpful. Respiratory weakness, think of the risk of respiratory failure, and in these cases you consider that the child may be admitted. And motor delays which present during minor acute illnesses, it could be a undiagnosed mitochondrial myopathy. If there is loss of milestones, motor milestones, think neurodegenerative. If elevated creatinine kinase more than 3 times normal, think that muscle destruction may be happening. And if there are abnormalities in brain MRI, you see whether an additional neurosurgical involvement is needed, especially if there is hydrocephalus or other conditions where a neurosurgical intervention like Arnold-Chiari malformation, where it might be helped by a neurosurgical intervention. So a few pictures: Gottron papule in the case of dermatomyositis, pes cavus in the case of a peripheral neuropathy, and scapular winging in the case of muscular dystrophy. So based on the possible diagnosis, we might need to do some blood investigation like anti-acetylcholine receptor binding antibodies by radioimmunoassay, which are positive in 85% cases of generalized myasthenia, 50% in ocular. Then in addition to the nerve conductions and EMG, sometimes repetitive nerve stimulation may be helpful in suspected myasthenia, where Neostigmine challenge test is also helpful. If there is ocular or cranial myasthenia gravis, we also need to rule out the intracranial lesions by CT or MRI, and we have to individualize the type of investigation chosen. So one child who responded well to Neostigmine, initially having ptosis and the eye opening after the Neostigmine challenge test, a test for screening for myasthenia. Now coming to the predominant language delay. So predominant language delay may be either because of input problems, like there may be a hearing impairment which is undiagnosed, or maybe the language impoverished environment is there where the parents are not really talking to the child and is just being offered maybe too much of screen time, or developmental disorders like autism, global developmental delay, or required epileptic aphasia like Landau-Kleffner syndrome, or output problems, maybe speech articulation disorders are there, or it could be a developmental language disorder. So how do we evaluate? We take the history of the risk factors for hearing impairment. We look for the presence of impaired social interaction, verbal and non-verbal communication, and repetitive behavior or sensory issues. We look for epilepsy. We see how much is the social support and what is the family structure like. Do a formal hearing and language assessment. The screening tools that may be used could be like MChat for autism. For confirmation of the diagnosis of autism, we can use the diagnostic tools like DSM-5, ICD-10, ADOS, ADIR. For language, we can use CAT clamps, and for severity assessment of autism, we can use tools like ESA or CARDS. So, very important thing, what are the red flag signs? These come from the IAP guidelines of normal development and when to suspect abnormal development. So this is a screenshot from there, and it is a very important screenshot that all of you need to memorize. So key messages include that one should determine what is the pattern of developmental delay. Look at the clinical clues which may guide your investigative pattern. So take a very good history and examination, and individualize investigations for causality because it has huge implications, and treat accordingly. So let all hues coexist. Identify and intervene early in a case of developmental delay. And these are few articles for further reading. Thank you very much.